Martin, what's your 30-second intro?
The answer to the question is superhero, if anybody wants to know. I'm Martin Marshall, I'm Professor of Healthcare Improvement at UCL, and I head up an organisation called Improvement Science London, which operates across the whole of London, attempting to embed an evidence-based approach towards improvement. I'm a GP by background, work just down the road in Lambeth. I don't have any formal responsibilities as far as information governance is concerned, but I'm interested in improvement. You can't improve without data, and the utility of data and quality of data is very important to me.
Hi, I'm Robin Burgess. I'm Regional Head of Intelligence for NHS England London region. And my role is across the whole intelligence spectrum, trying to improve the quality of information available within commissioning and, of course, within direct clinical care, and to try and improve its quality, people's competence in information, people's willingness to use data and to use it sensibly to improve care. And within that, IG is clearly an issue. It's particularly an issue at the moment, as many in the audience will no doubt say, for commissioners, and working very hard to find solutions to some of those problems.
Thanks. I'm Phil Kozan. I'm the Chief Clinical Information Officer for UCL Partners. So one of the new breed of clinicians or new roles that are bridging the gap between the clinicians and the IT technical environment. And within my role within UCL Partners, we're looking at how we bridge the gap between the research agenda and the NHS, and how we can actually first of all share data safely and securely within the NHS for improving care, being able to measure how we deliver that care, measure the quality of care, but also making the data available for research. And within the wider spectrum of CCIOs, looking at how we can work with clinicians within individual trusts that have got an interest in this field. The first journey on this has been to develop a piece of work working with Stephen Elgar that I'm sure some of you will know, looking at trying to get an understanding of where we are within the current spectrum of information governance across UCL Partners that covers most of North East, North Central London, parts of Essex and Bedfordshire and Hertfordshire.
Hi, Mike Cook, Director of Monmouth Partners, but my background is I've been working in the NHS since 1988, mainly in the information systems development bit. National systems, national cervical screening system is where I cut my teeth. Been involved in actually working with patient data, having to understand it, protect it, implement the Caldicott recommendations from the first review, and in those national systems. Ended up in my NHS career as head of the information data standards area. So read codes, IG toolkit, how do you codify information, how do those data sets and information sets flow. So more recently, having responsibility the other side of the fence, which is actually managing the equivalent of a data management integration centre prior to the changes that have come along, where we've done risk stratification, taking information from GPs and looking at the implementation, the practical implementation involved in systems terms of how do you give access to that information, how do you control access, and the legalities of getting that information in the first place. So,
Let me just kick off in terms of all the talk in the NHS and indeed around social care is around culture change at the moment. You only have to listen and read the papers, listen to radio and read the papers to get that. And information governance, as Dame Fiona has talked about, is no different. It's all about culture change. What are your reflections, maybe Martin, on how culture has changed around the information area and what really still needs to change?
I was having a conversation with somebody earlier about this, and they had a very positive viewpoint on how the culture has changed since 1997 in the health service. That might be the case. I've got to say I don't see it. When I spend all of my time talking to clinicians, to primary care clinicians, to secondary care clinicians, and these are people who don't live and breathe information governance in the way that you guys in the audience do. And I think they still have very traditional views about what information governance is. Indeed, they don't use the term, they don't think about the term on a daily basis. They have traditional views around confidentiality. They're very committed to data confidentiality. They're quite unusual in the way that they use information, sometimes remarkably willing to share it with a wide variety of people, and sometimes very closed about sharing it. I don't think they think about information governance. I'm not sure they know very much about Dame Fiona with respect to her or the work that she's doing. So I think there's significant cultural challenges that face us. I think we need to be clear what we mean about culture here. This isn't just about shared behaviours, which is one aspect of culture, the way we do things around here. This is about mindsets. This is about the way that people think about their roles and the respect that they give to their patients and the information that their patients has given them. So I think there's a significant cultural challenge. I think we've got a long way to go before we really start embedding some of the stuff that we'll be talking about today into the mindset of most clinicians.
Thank you. Anyone else want to come in, or should we open it? Fiona.
Do we need to put these on, or they're working? I just wanted to make the point that one of the things that we were struck by was that the very term information governance is part of the problem. And if it had been seen as part of clinical governance, which is where it actually belongs, I mean, yes, it needs the technical support, but it's primarily about the care that people are getting in the organisation they've come to. And so when I've talked about it, I have tended to say, if you think of it as part of clinical governance, then you don't have some of the worries about it that come from information governance being something the CIO does. I just wanted to make that point because I think it helps in thinking of it centred in the care of the individual. Thanks.
Thank you. Mike?
Yeah, just interesting because we were talking about this earlier about what's changed since the last time. And I think from my world, which isn't the clinical world, it's more about the technology and how do we protect information and share it appropriately, and how does technology help that? Actually, I think in my career, it's changed drastically since the first set of reports. I think there's in the sort of group of people that I deal with on a regular basis and have with over the years, the understanding about data flows and sharing of information and whether it's appropriate or not are things that are asked all the time and sit there behind the scenes. So in that sense, I think there's been quite a significant culture change.
So over to you. We've got a couple of roving mics, which I shall... Do you want to stand up? You've already got the mic. Sorry, yes. I couldn't see it. And then we'll go over here.
I'm Ben Lucas, Caldicott Guardian for Central and North West London Foundation Trust. We were trying to digest the report within our trust, and many of the recommendations we thought could be possible, but one that we were struggling with was the recommendation about providing patients with an opt-out of giving information to the information centre. So our executives are anxious about their getting security for their income streams. We struggle to get the information flows to support us as a provider organisation in meeting the requirements of our funders. So I'd be grateful for the panel's views on how either identifiable or de-identified information, how we could provide, using that, how we could provide that opportunity for patients to opt out of giving their information to the information centre to
Great.
Support the overall NHS.
Thank you. Let's just take a couple of questions so the panel can have a little think while we go. So over here.
Hi, I'm Oliver Harrison. I'm working as a consultant for the World Health Organization in a program looking at using mHealth applications to tackle NCDs. I have a question about the practical work of implementation and learning by doing, and how some of the technical work in taking the excellent Caldicott 2 report and turning that into technical specifications will interface with practical work on the ground to make sure that we're able to learn from practical experience and we're able to disseminate that experience more broadly across the NHS.
Okay, do I get one more? Has anyone got it? Has anyone got the mic? Yeah, great. Why don't you bring it round here and then we'll come here next.
Hello, I'm Philip Robinson from Imperial College Healthcare NHS Trust. One of the things that we've been dealing with is a lot of clinical registers that kind of were developed by clinicians, like condition-specific clinical registers. And would it help if we could have national guidelines for the provision of these clinical registers? Because often they're being developed by motivated individuals and don't necessarily have any particular standards applying to them.
Okay, great. Right, so we have a question about the whole opt-out issue, patients opting out of having their information shared, how the development of technical specs can interface with what's really happening on the ground and inform each other as time goes on, and this issue of clinical registers and such like. They've been developed for awfully good reasons, I imagine, yet also create the problems of variation in the standards they apply to. Mike, do you want to kick off?
Yeah, please, if I can. I think I'd like to tackle all three in one go.
Briefly.
Briefly. Oh. I think that the thing around opt-out, part of my work is I'm part of the UK terminology board, editorial board. And so that maintains the interest I've got in the coding schemes that sit behind some of this. And I know, both from that work and from work I've been doing in terms of delivering service, that there are certain codes, certainly in read codes for allowing people to opt out in terms of sharing their data and where they want to share it. And I know that there are discussions ongoing with NHS England around various codes that will allow opt-out from various things. I think there's a lot of discussion about that, but codes do exist. I think where the danger is picking up the second point of the question, is the guidance that sits around that and the usage of those codes. So I know from the work I've done in terms of the risk stratification and data sharing associated with that, is we've had to interpret those codes and how they will be used within systems. And I know from GP practice systems, those codes are used in different ways by different practices. How that relates back into the secondary care in terms of the first person's question, and how those codes might be used there, I think there's a lot of guidance and work still to be done in that particular area. And the final picking up the clinical registers bit, and then I'll shut up, is that I think, yes, there is a lot of data out there, a lot of registers out there. I think part of it, unfortunately, from a technical point of view, you have to go back. If we can get the guidance on the codes that you can use, you can start applying those in those registers, and then we can start, in an electronic sense, deciding what's appropriate to share and whether people have consented for that or not. So I think there's quite a bit of work there.
Phil, do you want to come in on this one?
Okay, thank you. So I think just very quickly, as far as the opt-out is concerned, I was involved in the summary care record rollout in a previous life, and there was a lot of talk there about the opt-outs and the way that we do it, the way it handled consent. When we actually came to rolling out the summary care record, less than 1% of patients actually opted out. So I think that it's about having the mechanism to do to have that facility, rather than expecting a vast majority of the population to opt out. So for me, it's important that there is a process there, and we need to understand how that process works. And I think the bits around the technical practical implementation and the work in clinical registries, what we're doing within UCL Partners is having a discussion across the whole spectrum of people involved in this, to start by understanding what's happening at the moment, where do we need to change, and where are the quick wins, what can we do short term, what can we start now, where do we need to wait for longer term guidance. So I think it's important to make sure that we look at what's practical and what are the technical requirements, do that hand in hand rather than wait for something to be dictated.
Thank you. Robin, do you
just on the one about the opt-out, clearly it's vital that even if there is only 1%, it's crucial that people should have that opportunity. And again, in previous lives, I worked for 20 years in substance misuse treatment and then policy and all the rest. And a significant population there really doesn't want their data shared for perhaps obvious reasons. So we have to find ways of doing that. And there are technical ways of doing that, certainly within GP systems. NHS England is just about to launch a consultation about GP extracting GP data to be part of the new care.data system. And we will have to offer that opt-out to individual patients, and that will come very shortly. So we're working that through at a technical level, at a practical level, very strongly in the immediate future, and that will be rolled out from next week onwards. That whole process of consultation is going to take place. So that's an example of making it real in practice. And the other point I want to come back to was the clinical registers. Again, in a more recent previous life, I had responsibility for commissioning all the national clinical audits and maintaining registers of the registers. And in dealing with them, it was quite clear that some researchers really just wanted access to everything for the purposes of the secondary use that they were concerned with. And there was, frankly, some poor practice in terms of care over the way that they handled some patient identifiable data within those systems. So it is really important that we ensure that within that area of secondary use that there is proper control of access to identifiable data within the law. And it is an area that needs work, and it is an area that needs the kind of standards that you were talking about. I think, if I interpreted you correctly, you're nodding, so I think that's right.
Thank you. Who else has a question? Got one here. What about over on Rebecca, and one over here?
My question is for Robin Burgess. I'm Alpha Sadhu, a consultant geriatrician and medical director at Ealing. And Ealing has the enviable position of being an integrated care organisation where an acute trust has taken over the care of community services of Brent, Harrow and Ealing. And one of my most difficult challenges in the last 2 years has been the fact that the cozy relationship that used to exist between the provider and the commissioning arm of the PCT meant that the information was liberally shared in a way that I think was not fit for purpose. And the major challenge I have been facing as Caldicott Guardian for the ICO is the fact that the Commission has been asking me for patient identifier information to a sort of street or ward or, GP level that almost makes it, imperative, or makes it very easy for patients to be identified. What's your response about the new organisation and the new commissioning groups and what they will be looking for?
Thank you. And there's a question here.
So Kieran Seal from 4 Central London CCGs, and it's sort of the other point of view from the last question, really. It was very interesting to hear Dame Fiona talk about the dangers of risk-averse behaviour and duty to share, and I understand that direction, and it sounds like the right direction of travel to me. And in a CCG, since the 1st of April, we're in a much more restrictive environment than we were before the 1st of April. So that seems to be heading in completely the opposite direction, and so I'm a bit confused.
Thank you. Let's take 2 of those. Funnily enough, those were questions in the area that we predicted would come up quite quickly. Who wants to go for it first? Fiona, why don't you kick off and then Mike?
If I could start with the second one, I think the difficulty is that there hasn't been enough consideration given to how this would work 1st April onwards. And I think it's important to be very clear about the need for identifiable data for certain purposes which are not direct care. And I don't think the answer, with great respect to some colleagues, is to start arguing about what direct care is. I think most of us have a pretty clear view of what direct care is, and it's not the same as secondary uses, which is such matters as making sure that the invoice you've been given for care has been fully worked through by a provider organisation. I think it is one of the areas where we need guidance and Secretary of State's response. I know there's a lot of work going on in NHS England. There's been a letter from a number of representatives of CCGs to Christine Outram, who is Tim Kelsey's number 2, about these very issues, and I hope there will be some guidance before the response to our report in September, but certainly by then. Meanwhile, there is in place a Section 251 to give access to some identifiable data on certain quite strictly controlled definitions. So I think there are solutions to some of this. And of course, the example I tend to give is that the patient who wants a particular rare treatment will, of course, consent. So thinking about those issues where patients will consent is one way through it, but there are areas where commissioners want identifiable data where I'm afraid I don't think under the current legislation they can justify that. So I think there's a need for solutions very quickly. Then coming back to the first question, I think it relates to the same point. Does the person asking for the information have the right to identifiable data under the law, i.e. the Data Protection Act? And if they don't, then the Caldicott Guardian has a very clear position that this is not available to them under those terms. And yes, solutions need to be found, but not through just giving identifiable data when there aren't grounds for doing so. So I'm afraid that's, if I might say so, a rather clear parameter, but it's not one that everyone accepts. So it needs the support of other Caldicott Guardians and national advisory systems to support that view.
Thank you. Robin, let's just have an NHS England point of view.
I mean, it was interesting. The two questions really neatly polarised the issues. As a clinician, you were clearly concerned that commissioners were looking for far too much detail, which, as Dame Fiona clearly says, is not lawful under the law as it is currently. And do they need that? Why do they need it? What do they need it for? And there are a range of purposes that commissioners need information for. Whether they always need identifiable information is one we could argue over for a week and more. At a practical level, I'm pretty much spending all my time on information governance and this specific issue at the moment. And the second gentleman who spoke, unfortunately I couldn't see, highlighted the very real challenges that are out there for commissioners. And that includes us. NHS England is a huge commissioner of services. It isn't just within, of course, CCGs, and we are as much affected by these very real challenges in terms of invoice validation, for example, the risk strat stuff, as everybody else. So we do need to find solutions, and that's where we come in. I work ultimately to Chris Outram, who was just mentioned, and Chris is heading up a very senior programme group across NHS England, working very closely, of course, with the IC Information Centre, to come up with some solutions to these things. And Dame Fiona mentioned one, the 251. There are a variety of others. The 251 that's currently in place, for those who, I'm sure you all know what a Section 251 legal support is, which enables certain types of data to be shared in certain circumstances under approval from the CAG, which reports to the Secretary of State. So the 251 that's currently in place allows certain sharing of information, but it doesn't allow for others. So we have to find other solutions for some of the other problems that are out there. Some of them are very challenging indeed. And the issues are to do with structures, to do with capacity, to do with the volume of people who are skilled in this area of work, where they're based, the relationship between regional bodies and national bodies. It's horrendously complicated. And working through those solutions is pretty much a full-time job. And I sit on the working group that is the task force that's now in place. The task force is looking to recruit far more bodies who are going to do these practical pieces of solutions within the law to enable the data to flow, to enable commissioning to work. It will not be easy, will take time, and that we may well need to look at consideration of more radical solutions. The law change is certainly one for the Department of Health to consider. It's not for us to consider. But the message I really want to get over to you is that this is recognised at a very, very senior level within NHS England. It is being addressed with the right degree of tenacity and leadership, and we are working very, very hard to come up with the solutions that are needed to address these problems.
Thanks, Robin. I suggest, given time, let's go for another round of questions, and then if anyone wants to pick up anything else. So I've got one at the back shot up and another one on the back of that side.
Andrew Babbage, Information Governance Manager for Social Care in Redbridge, East London. Observation, if I may, disappointed that there's nobody from social care on the panel. However, the question is, bearing in mind that we're talking about improving trust between health and social care, what does the panel think? How can we do it? How can we improve trust between health and social care?
Thank you. Who was my one at the back?
Hello there. Andrew's just stole my thunder a bit, actually. It was really to get this round on a social care. I'm Wendy Pack. I'm from London Borough of Wandsworth. And leading on from what Andrew was saying, I mean, one of our major concerns in social care is obviously the extension of how that goes across the whole of the council. You know, with housing, we have to share with, and all the other departments. And that's something that is really concerning to myself as a social care person.
Let's take another.
I'm Mimi Morris-Cottrell, Public Health, London Borough of Bromley. Echoing the other questioner, is actually surprised to see that we haven't got a representative from NHS, Public Health England, because there have been quite a number of conferences around how we can actually share information in public health in the boroughs. I haven't got a question, but it really is a plea in finding solutions for the various questions. Just don't forget public health in the borough, because I think there's a lot of talk about how information can be shared within the NHS family, but we in public health undertake quite a lot of work, but not in the NHS. Thank you.
And I think that will be some of the challenges for the community, is to sort of identify all the areas that need work, and we've got, you know, we have time to address. We can't address everything today, but we will work it into a future programme. Can we just to pick up one question here and one question back there?
I'm Janice Abraham from Enfield Council. I just want to know what the proposal is for accredited safe havens. Safe haven, the term, has been around for quite a few years, but there's some new guidance come out that's referring to accredited safe havens, and I just wonder what that proposal is.
And where are you from? What's
Enfield
your
Council?
Right, thank you. And one more question back there.
My name is Penina. I'm from Public Health England, and I notice a few faces from Public Health England here as well. So I think we are here. My question really is for Dame Fiona. You mentioned the role of the educating the public is important, and I agree. In your views, and indeed for the rest of the panel, who should take up lead for educating the public? Should it be NHS England or Public Health England, or indeed others? And alongside that, what are we doing to promote health literacy?
Thank you.
Question for the
So we've got a little smorgasbord there. There's the issue around how to go about building trust between health and social care on the ground. Where public health fits in, and some of the challenges there that take the question of information sharing beyond just health and social care in particular. Specifically, a question around accredited safe havens, if anyone is able to pick that one up, and where the responsibility for educating the public lies. So, Phil, do you want to kick us off?
Okay. I think the issue I wanted to look at was really that of trust between health and social care. And I think it's an area where probably the information governance bit is a relatively small part of that jigsaw. What we need to do is work together a lot more closely between health and social care than we are at the moment. As we develop integrated care organisations, I think that trust will come as we develop that understanding. I've certainly done a lot of work in the past with social care colleagues, and probably understand a lot more than an average clinician. I think the IG will hopefully fall out of the bottom of that as we develop those relationships. And then the other bit I wanted just to mention was the educating the public. One of the proposals that's coming forwards at the moment is around patient access to their records. There's a lot of work that's being developed through the Royal College of GPs as the Access GP record is a 2015 target. And I think the education will actually start as we allow patients to access their records and really start talking about patient control, patient access, and what that means.
Thank you. Martin, and then Mike.
So also a reflection on possibly the most complicated question about the health and social care divide. I agree with Phil that information governance is one small part of a much bigger issue, but actually it's a really interesting and useful small part, a good exemplar, maybe even a touchstone for how relationships could be improved. If we're talking about improving trust generates through conversations. Why don't we start having conversations about how to share information across the divide and use that as a broader opportunity to build more powerful relationships. I'm doing a lot of work with Newham at the moment, working between the Council and CCG over the Olympic Legacy Project, the establishment of a new health service within East Village. Really interesting discussions are being had there, which I've never heard before in the relationship between councils and the NHS. And we're starting to look at information governance and information sharing as one of those areas. So I think it's a really good example of how we can start conversations in an area in which we can find some common ground. And I have to say an area in which I think the health service has an awful lot to learn from social care in this respect. The other issue, just very quickly, relates to what conversations we need to have with service users, with patients, with clients. One of the things that I'd like to see is a change in the language that we use. We do differentiate between primary and secondary use of data because it's convenient for us to do so. But actually from the user perspective, I'd really like them to see those two things as one. So if they are part of the National Health Service, then they have both rights and responsibilities to use their data for their clinical care, but also for service improvement and also for generating new knowledge through research. So this division between primary and secondary use of information seems to be extremely unhealthy and something that perhaps we should get rid of when we start having conversations with service users about it.
Thank you. Mike?
Yeah, pick up the bit about safe havens. I share your view on that. Safe havens have been around for a long time and I've been party to operating them. So it's interesting to see what the Information Centre will come out with in terms of how this accreditation process will work, and I'm in conversation with some people in that organisation to work that through. Just from my work in the equivalent of a data management integration centre, which was a commercial organisation that needed to set that up, contractually we were bound by very, very rigorous contractual requirements around the whole confidentiality, security issues around data, far more so in terms of any other organisation in the NHS that I've worked with in the past, in terms of what hoops and procedures and systems we had to put in. So it took the safe haven ones and all those other things and put them together in a contractual sense. And I think there's something about contractually, how do we work going forwards between NHS organisations, having some sort of contractual thing in there, even if it's only for the value of £1, but actually getting legal contracts in place for dealing with some of this stuff. And just picking up on the trust bit between public health and social care, and it's only a personal view from conversations I've been having recently with organisations, especially the DMICs. I think some of that comes about by what people are asking for. It goes back to the whole commissioning bit. I mean, I know people from a public health background that have said, we would just want all the patient identifiable information, just give us everything. And when you start getting into a conversation about, well, what do you want to use it for? How's it going to be used? What's the purpose? Then that trust starts to break down. So I think it is about talking. I agree with everything that's been said so far. But I think some of that culture changes is because people's expectation is being asked and being expected to get everything. And now there's a clear marker from the report that's been produced that says actually it's time to stop that practice and let's rethink it.
Thank you. Anybody else on the panel want to chip in with some final comments before coffee? Robin?
I was just going to mention about the ASH. Perhaps if you want to, the coffee break, take it up with me directly. I mean, the new ASH is, for which the accreditation process is pretty much ready, isn't it, from the IC, although the cost of it is not clear at the moment, will not offer a solution to all of the needs that people have. They offer one solution to one bit of the whole broad agenda. But it is a very good example of how, when you start to work it through in practice, the theory of having a few ashes and not very many, it looks like it's not going to last, and there will probably be quite a lot of ashes out there, and we're just working that through.
Thank you. Fiona.
I was just going to respond to the question about public education. I think we all have a responsibility because it depends on where you're working. I absolutely take the point that the access to the general practitioner's record will make a huge difference in this area. But I also think there's a need to try and identify ways of relating to members of the public who are not currently patients, but who may well have attitudes to how their data is used. And I think the whole social networking set of questions raises some very interesting questions, back to the interesting one about Edward Snowden and whether he was a villain or a champion. I mean, I do think that there is now much more awareness amongst members of the public, some of whom are patients and service users, that there's huge potential for damage through the movement of information. And I just think we have to be sensitive, according to whichever group of patients, people, citizens we're relating to, that there's a need for them to, this sounds a little bit patronizing, but I think there really is a need for people to have more information put to them about some of these questions so that they can come to a view. I'm really interested in why people have accepted internet banking in the way they have. Now, I know there are differences between your financial information and your health information, but I think there are some lessons for us to learn in how that industry, and I don't always praise them, but how have they been able to get public confidence in that area? And I think we should look beyond health and social care for some of the answers. Yeah, thank you.
Thank you. Well, we've scratched the surface of lots of great questions and issues.